So, good afternoon and a very warm welcome to all the doctors who have joined today's webinar. I'm Neetu Abraham, Community Manager at MediSage eLearning. At MediSage, we empower doctors with the right blend of knowledge and technology to enhance clinical practice and patient outcomes. With AI transforming healthcare, we are excited to introduce Sage AI, a medical grade AI built exclusively for doctors. This entire webinar is co-powered by Sage AI and it is now freely available on MediSage app, offering reliable evidence-based support anytime and anywhere. On behalf of MediSage, I am delighted to welcome you all to Sexual Health Ki Pathshala, episode 9 to SexMed Connect, where today we will be discussing on the topic all about orgasm. With this, I would like to hand over the session to Dr. Shama Sultana ma'am. Over to you, ma'am.
Thank you. And good evening, everyone. On behalf of SexMed Connect Sexual Wellness Forum for Obskyne, I warmly welcome you all to today's episode 9 of Sexual Health Ki Pathshala. SexMed Connect is a dedicated academic forum for obstetrics and gynecologists focused on advancing knowledge in sexual medicine. It is initiated by President Dr. Neeraj Jadhav sir, Vice President Dr. Apurva Datta sir, and Secretary Dr. Shama Sultana, and Joint Secretary Dr. Naisargi Patel and Dr. Vaidehi Thakur. It provides a platform to learn, discuss, collaborate, and share evidence based practices to improve patient care and promote sexual well being. Through its WhatsApp community, Instagram, Facebook, and YouTube platforms, SexMed Connect delivers regular academic updates, expert discussions, clinical insights, and educational resources, helping gynecologists stay connected with the latest developments in sexual health. Together, let's connect for knowledge, break taboos, and build confidence in sexual medicine. Today's topic all about orgasm. We say as रिश्तों की गहराई सिर्फ साथ निभाने में नहीं होती, एक दूसरे की खुशी को समझने और अपनाने में होती है. जहां संवाद, विश्वास और सम्मान का संगम हो, वही सच्ची अंतरंगता का जन्म होता है. So, like this, orgasm is more than just a climax. It's a complex interaction of brain, body, and emotion, hormones, and relationship dynamics. It is an important indicator of sexual well being, quality of life, not merely a sexual performance. Open communication, proper counseling, and evidence based treatment can significantly improve sexual satisfaction and intimate relationships. For this, today we have privilege to present an important and often misunderstood topic all about orgasm by our none other than honored guest, Dr. Vijay Sarthi Ramanathan sir. Our esteemed faculty, I request my co-host to introduce our esteemed faculty, Dr. Vijay Sarthi Ramanathan sir. Over to Dr. Riddhi Shukla ma'am.
Thank you, Shama. Good afternoon. It is my great pleasure to introduce our distinguished speaker, Dr. Vijay Sarthi Ramanathan. Dr. Ramanathan is a renowned expert in sexual medicine, psychosexual therapy, and sexual health education with over 15 years of clinical, academic, and research experience across Australia and India. He is a senior lecturer in sexual health at the Faculty of Medicine and Health and University of Sydney, an internationally respected educator and researcher with a PhD in sexual health from the same institution. He has trained countless healthcare professionals, authored numerous scientific publications, book chapters, and is a fellow of both the European Committee of Sexual Medicine and Higher Education Academy UK. He is also practicing psychosexual therapy and sought after international speaker on sexual health and reproductive medicine. Please join me in extending a warm welcome to none other than Dr. Vijay Sarthi Ramanathan. We look forward to learning from his wealth of knowledge and experience. Thank you very much, and the stage is all yours, Dr. Vijay Ramanathan.
Thank you. Thank you, Dr. Nidhi. And thank you, Dr. Neeraj, for inviting me. And Dr. Shama, I think you've done a wonderful introduction to the topic. So let's get started. Let me need to present. All right. So just tell me if you can see my screen.
Yes, sir.
Yeah. And you
Yes,
can
sir.
also you can hear me well. Yeah.
Yes.
Wonderful. All right. So let's get started. Now, in the past, I used to give a talk very much on female orgasm and female orgasmic disorder. And even on your invitation, I assume, which I generally don't do, And I don't encourage anyone that I train to assume in sexual health. It's a very risky one. But I think the hands here represent very female hands. So I think there is a notion this topic is going to be all about female orgasm and female orgasmic disorder. However, I've taken the liberty to include male orgasm and male orgasm, delayed orgasm or anorgasmia. And I'll tell why that is very important. Yeah. Now, I know it's Sage AI, which is fantastic, Neetu, to hear about the technological developments. But I can assure you all that no AI has been used in creating this presentation. This is purely my knowledge and from literature and also from my clinical experience. And I think the introduction already there. And I'm not part of any pharmaceutical company or anything. And I declare no conflict of interest in me doing this presentation. And no brand names of any medications will be used in this presentation. So now, before getting into the topic, I want to highlight few things. Now, the fact that we are talking male, female uh, is none but a very gendered language. And a lot of literature that I'm going to refer to and a lot of information that I'm going to present is also based on cisgendered male and female. But it's high time that in the professional setting, that healthcare professionals like you and me, we should start looking at people who don't fit into that cisgendered profiling. Okay, so we need to be mindful of trans people. So, and we need to address their orgasm and their orgasmic difficulties. But the reality is, as much as we can acknowledge, we are very mindful and to address that as a limitation. The problem is we don't have much data now. But what we know about orgasmic issues in trans people, it's one of the most common problems. So that's a reference there, and I've given the reference as well. There aren't many articles, but the trend has started to come in. So they are looking more and more into trans people, and we need to be mindful of that. We need to be accommodative of that. And going forward, as the organization, as the professional peak professional body, Foxy, it's not just about cisgendered male and female population. We need to be more mindful and respectful and inclusive of trans people and their problems. So I thought I'll highlight that. Now, learning outcomes and overview. What are we going to do in the next 70 odd minutes, right? So, but before that, why are we here? So at the end of the session, what are you going to learn? What you're going to leave the session with? So definitely you'll be able to define what orgasm is. More importantly, as Dr. Sharma said, it's not just climax or a performance. What is the role of orgasm within the overall human sexual response? And also, you'll be able to explain orgasmic disorder. So let's start with what is normal, what is physiological, and then we will slowly move into the orgasmic disorder in females and males. And then we'll also go through what are the management options. How do we manage? And for that, I'm going to present a case study, a real case study that I had to deal with, a female client. And then if time permits, I'll also go through a male client. A lot of you might know, like may not even have a click that male anorgasmia or delayed orgasm is something that exists because it's often tucked under delayed ejaculation, right, in men. But we need caution there because ejaculation and orgasm happens very close in men but they are two distinct process. They are not same. So there is more growing recognition that orgasm and ejaculation needs to be addressed separately in the male population. So that's sort of an overview of what we are going to go through today. Now, in a ideal setting, I would love to have this as a very dialogue, very interactive, but I understand the limitations of technology. So I'm going to go run through the whole session and then we'll take questions at the end. Yeah. Now let me do some sense check. Dr. Neeraj, Dr. Riddhi, am I talking too fast? Is the speed okay? Am I clear?
Yes, sir, clear. It's okay. Perfect.
Fantastic. All right. So if you can't hear me, if my slide gets stuck or something, please let me know. Yeah.
Yes.
All right. So what is this thing called orgasm? And I couldn't. So what is this thing called orgasm? Now, can one definition precisely describe every aspect of orgasm? Definitely not. Now, there is no standardized definition of what orgasm is, which is a problem when we trying to understand the prevalence or incidence of orgasmic disorder, because we don't know, we can't clearly define what orgasm is. However, we have some operational definition, but it's not a standardized definition. So that's something you need to be aware of. So orgasm is generally seen as the peak, and that's where the notion of climax comes from. Okay, so the peak of sexual pleasure, right? Now remember, if you deconstruct that definition there, you'll be able to appreciate there are so many subjective elements, right? Pleasure, for example, what is pleasure to one person might not be the same to the other person. And even for this one person, what was pleasurable 5 years ago may no longer be pleasurable now. So there's a lot of subjectivity there, and we need to take that into consideration. Now, everything I say, I'm not just saying for the sake of saying it. When we look at the case study, when we look at the management, all of this is going to make a big difference, because sometimes we cannot pathologize someone and give them a diagnosis of orgasmic disorder. Okay, so we need to be aware of the subjectiveness. So let's look at the definition: a peaking of sexual pleasure with release of sexual tension and rhythmic contraction of the perineal muscles and reproductive organs. Now that's a lot. Hang on a second. Which reproductive organs are we talking about? Which muscle contraction are we talking about? So we need to be very careful, and not everybody is going to experience the same level of muscle contractions. And there could be so many other pathology that could be inhibiting that experience. There could be medications could be inhibiting that the sense of muscular contractions. So it's there, but it's not a very standardized definition, right? Now let's look into the female. So in female, there are contractions of the wall of the outer third of the vagina. Now, as you're all obstetrics and gynecologists, I'm not going to, talk the anatomy, but the lower or outer one third is the most sensitive part in the vagina that has the most nerve endings, whereas the upper two-third, there isn't much. There's hardly any nerve endings to be feeling that's sensations. So, but what is that structure that surrounds the outer one third of the vaginal opening is also the clitoris. So what are we really talking here? Now, this is very important because there's a huge controversy, there's a huge myth that vaginal orgasm is superior to clitoral orgasm. Now, we will look into that later, what it is, right? But technically speaking, what is being stimulated in a sexual intercourse, quote unquote, penis inside the vagina in a very heterosexual context is actually on either sides of the bulb of clitoris is what being stimulated even in a vaginal intercourse. So that's something we need to be mindful of, right? Now, the anal sphincter also contracts during the orgasmic phase of sexual response. So there's quite a lot happening in the pelvic floor during orgasm, and which is fantastic. And that's why physiotherapists, especially pelvic floor physiotherapists, have a significant role in helping men, women who are undergoing or having difficulties with orgasm. They do play a significant role there. Now, looking into female sexual response cycle, now where do we start? Right? For a long time, women have the female sexual response has been ridiculed in a way, or men are very easy. Even there used to be pictures of showing male sexual responses very simple and straightforward, just one switch up and down, whereas female sexual is very complex. I think it's high time we debunk and move away from those stereotyping, and we need to look at every individual as an individual person. Now, let me warn you, great Rosemary Besant's circular model, very popular. It's been adapted, evidence-based, fantastic, no doubt about it, right? However, we cannot assume that every woman on earth is going to have a circular response. And for that matter, not every man on earth is going to have a linear sexual response. That is not necessarily true. And the notion that has been very popular is that women need to be emotionally intimate in order to be sexually aroused. Who says that? On the other hand, men are always stereotyped as saying they just want sex. They're not that fussed about their emotional intimacy. They just always want sex. And that is not true either. Now, what I'm trying to allude is there are women who like to have just sex. So that's spontaneous sexual drive. That's perfectly fine. They don't always need, not all women always need emotional intimacy. And men, there are some men who also like to have that emotional intimacy before they can feel aroused. So the key takeaway from here is, if at all you remember men linear pattern, women cyclic pattern, great, 80% of the times correct, but allow there are some exception to these rules. Now, let's look into the majority of what women female sexual response cycle looks like, and then the exceptions are always going to be there. So where do we normally start in explaining this? From emotional intimacy. So women who are seeking emotional intimacy are at a state of either being receptive to sexual stimuli or seeking out sexual stimuli. So women wanting that connection, that affectionate, that intimacy, and then when their partner does something to them, and that could be any form of stimulation, they actually develop desire for sex as opposed to having desire at the sexual desire as a starting point. And that's a big difference. But once the stimulation is there, it's not just simple. There are so many biological and psychological factors that intermediates the sexual stimuli and the sexual arousal. So even though they are wanting emotional intimacy, but once it gets started, there is a strong elements of biological and psychological factors which will enhance the sexual arousal, which will make a woman to seek out for more sexual stimuli. And this is very important. Now, in this psychological phase, if there is a trauma, if there was a sexual trauma, a molestation, or had any negative sexual experience, that's going to be a shutdown, right? Now, even though they respond to the stimuli, the automatic thoughts come into mind and they are going to be a shutdown. And it never going to progress to the next phase, which is the emotional and physical satisfaction, quote unquote, the orgasm. That's what is shown there. Now, for and if you look at the evidence in Archives of Sexual Behavior, a very old article, there are 237 reasons why people engage in sex. So it's not always for pleasure. There could be so many reasons why a person engages in sex. And it could be, yeah, that's very important. And so when a women wanting to have that emotional and physical satisfaction, a lot of factors could come in the way, and that's very important. Now, it's also important when a woman is not in that state of sexual arousal or being receptive to sexual desire, anything the partner does, touch or certain words they utter, could become a negative impact. I'm emphasizing this because when we do the case study, it becomes very important. Now, sometimes in a sexual situation, any derogatory comments made about the body shape, the body image, all of that could be a complete shutdown. And doesn't matter how much ever the clitoris gets stimulated, there is not going to be an experience of orgasm. And that's very important to understand. Now, we all know the main sex organ is the brain. But we should also understand, and I don't know how much awareness is there in India, but definitely I have done some work with a physiotherapist in India she's now working in the UK. We published a paper as well, but a lot in Australia, there is a heightened recognition of pelvic physiotherapist. Now, the reason I'm saying that is there is a structure, the pelvic floor muscles, which we don't give much importance at all. We do not give attention to it. But if you really look at it, the pelvic floor muscles, it's like a thick, strong group of muscles through which all the neurovascular bundles pass through. And it is that structure that holds a lot of organs and structures above it. And during orgasm, the pelvic floor contracts a lot. So even in the positron studies and brain imaging, the focus was always about which section of the brain flares out, which occipital lobe, gyrus, fusiform, and everything. But really, the study should start focusing on which groups of pelvic floor muscles really contract and what is the role of pelvic floor muscles during orgasm. I think that's a huge gap in literature in our understanding of the role of pelvic muscles. So the important is it is related to orgasm, and pelvic floor muscle contraction has a significant role in how a person can experience pleasure. Now, hypotonia, a lack of tone, might not give enough contractions. On the other hand, a very tight muscles, pelvic floor muscle, will make it very hard for a sufficient blood flow to happen. So either extremes are no good. So we want the optimum, the tone of the pelvic floor muscles, right? Now, there are other things that I have said as a gynec. I'm sure you all will know what could happen in an orgasm. So the physiological changes. So I'm not going to go through that. Now, one thing that is very popular in media and people make a lot big hoo-ha about multiple orgasm, and some men especially they watch pornography where they portray that multiple orgasm is such a common thing, and it creates an unrealistic expectation. When they engage in sexual activity, they expect that from their female partner if they are in a heterosexual context, when in fact this is where it's interesting. The debate is it multiple orgasms or is it one big orgasm that is happening in a very sequential way? It's a built up. So it comes up, goes down, comes up, goes down. It's like a comb. If you look at it, it's like a comb tooth. So it's really not multiple orgasm. It's one orgasm, but multiple ups and downs. So there is a contract. And sometimes even women have this notion, oh, I'm not able to have more than one orgasm. And they see that as a problem because they have seen somewhere or they've heard that women can have multiple orgasms. Great if they can, but it shouldn't become the benchmark or comparison. Okay. Now, the vibratory threshold, this is very important, right? Now, a lot of women who stimulate their clitoris. Now, clitoris is, as gynecologists, you may all know what clitoris looks like, but I'm telling you, a layperson might not know anything about clitoris, and that's very important, right? But once during orgasm, the vibratory threshold of the clitoris actually decreases, right? And it actually takes about 20 minutes to come to baseline after orgasm. So sometimes, and that's something important to be mindful of, okay, they put excessive pressure or they bite or they use vibrators, and sometimes they think, oh, it's not working, right? So it's important to be mindful which part of the clitoris they are stimulating. It's the glands, the clitoral hood, that is important, which is equivalent to the tip of the penis. And where they are stimulating is very important. And sometimes I often get asked, oh, I heard about this spot, that spot. But technically speaking, that's an exploratory exercise. Not everybody should have the same spot as the most sensitive spot. It's something an individual can self-explore or the partner could explore to find out which part of the clitoris is actually more sensitive. Okay. And no two women could, it's not a condition that two women should have exactly the same spot to be the most sensitive. And the amount of pressure, whether it is the pressure or whether it's a penis or from the finger, it varies from person to person. Now, I've already answered this. Now, Dr. Neeraj, I'm going to play a video. I don't know how far this is going to work, but let's see. Okay.
Yes.
And tell me whether it's showing up on your screen. Yeah.
No,
One
not yet.
second. That's a ad. Can you see the ad on YouTube?
No, sir.
Okay. Tell me what you're able to see on the screen.
Only your slide we can see, sir.
Okay, slide.
Which is,
Okay.
yeah.
Okay, let me share the screen. Hang on. Okay, one second. Uh, One second, one second. No, 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 it's not working. That's all right.
Okay.
No, that's all right. Let me go back to the presentation, but I will send the link. I'll send the whole slide deck and people can watch it. I think it's now you can see my screen slide. Yeah.
Yes, yes, sir.
Okay. All right. So please do watch it. It's a very educative video that you can watch. Now, as I referred before, every time we take orgasm, it's not a very clean, very standardized or very well researched area. There's quite a lot of complexities and it's a source of controversy, and some people get triggered, or this is all, not right. This is very male dominant field. You're trying to minimize the importance of female orgasm. There's quite a lot of controversy. Let's not go into that. But there are some common myths that needs to be busted. Okay.
Sir, need to
Now,
play that video if you want.
Yes, sir.
You can play that video.
Yes, sir. Vijay sir, you can send me the link. I will try to play
uh,
it from my end
okay, okay.
through chat box.
Yeah, I
Just
will put it.
yeah.
Yeah, 1 second. I need to stop sharing it because I really think it's a very important. Uh, uh, 1 second. I'll send it in the chat box. Oh, chat, and I'll put it to everyone. I've sent it to you, Nita. See whether you can play it.
Nitu,
Nita, are you there?
Nitu, where's he at? Are you there, Nitu?
No. Yeah, she's still there. Oh,
No,
she must
she
have
is left.
stepped out. Okay. Okay, let me keep presenting, and then when she comes, she can take control of it. Now, as I said, an orgasm is not a measure of a woman's reproductive fitness. So if a woman can't experience orgasm, it doesn't mean there is something problem with their reproductive ability. And also, orgasm has been given over importance, and there's a notion that it helps with better sperm transport. Great idea. Yes, if orgasm's there, yeah, why not? But has it been proven by evidence? Probably not. So we need to be mindful when we are suggesting such things to our couples, especially those who are coming with subfertility, that, oh my God, you're not having an orgasm. That's why there could be a problem. We need to be mindful of that. But often I hear gynecologists saying, oh, orgasm is good because then the pH will be more alkaline. It's good. But that doesn't necessarily have to be coming from orgasm. That could be purely happening from sexual arousal. So sexual arousal is important because it changes the alkaline, but doesn't necessarily link to orgasm. So those are certain things we need to be mindful of. And the most important is, this is also very culturally ingrained, that the orgasm should be happening from penovaginal intercourse and not necessarily by self stimulation or mutual masturbation or anything like that, or because that is somehow seen as inferior, or it's somewhat seen as dirty, because there's a lots of values in it, and there's lots of conditioning in it that it should happen through vaginal intercourse. But whether the orgasm is happening through vaginal intercourse or clitoral stimulation, end of the day, it is the pelvic floor and the clitoris that is playing the majority of the role in a woman experiencing orgasm or any form of sexual pleasure. The vagina per se, past the outer one third, there is literally nothing to do with vagina. And this is very important because sometimes men have to be educated on how a female sexual anatomy works, and to them, they might be trying to get it through vaginal intercourse, but overly focused on putting it deep inside and trying to stimulate, when in fact they may not be getting what they wanting to get. So it's important to make them aware of the sexual anatomy and physiology in a way that they can understand. Yeah, need to. I can see you coming. Do you want to play the
Uh,
video
yes,
or?
sir. Yes, sir. I got a net issue. Please share me the video.
So shall I stop sharing then?
Yes.
Okay,
Share me
I'll
the
let
link
you.
now.
I've already shared it with you on the chat.
Once again, I just lost it.
One second. Oh, okay. I'll put it in everybody's chat. Yeah. Mhm. Just confirm whether you got it.
Yeah, got it.
Yeah. Mhm. Dr. Neeraj, how many people we are having on the audience?
Me too, because
So we will know once the webinar is over.
Seven.
I will
Oh,
get the
wow. Okay.
details. Okay.
Okay. Okay. Okay.
I'm just sharing the video now.
Mm-hmm.
Let me know if you can hear the audio.
Yeah, we can.
Female orgasm is a complex psychological and biological experience. Reaching and experiencing orgasm is not the same for every woman. The orgasm can result from many types of stimulation, including clitoral, vaginal, and stimulation in erogenous zones, commonly the nipple area. For most women, orgasm depends critically on stimulation of the external glands of the clitoris. The clitoris has the most nerve endings in the human body. It has legs and vestibular bulbs that wrap around the vagina. The legs and the bulbs contain erectile tissue that fills with blood and expands when sexually aroused. Some women can achieve different kinds of orgasms from stimulation of select regions inside the vagina, such as the so-called G-spot and cervix, or a blend of the two. Erogenous zones are sensitive areas that can provide pleasure and sexual arousal when they receive stimulation. And the nipples are a common erogenous zone for many people. Each nipple has hundreds of nerve endings, making them super sensitive tissue. When the nipples are stimulated, they send sparks in the genital sensory cortex. This is the same area of the brain that's aroused by vaginal or clitoral stimulation.
Yeah, I think we can stop me today.
During arousal, blood flows to the genitals,
Later you can
causing
stop.
them to become more sensitive.
Yes.
Yeah. She's trying to. Mhm. Yeah. Thank you. That's wonderful. So I will start from where I left, which is, I think, important just to get an understanding that any part of the body that has rich nerve endings, and sometimes it could be the earlobes, could be the nipples, or it could be the great toe, but it's important for a couple to explore together or for a woman to explore on their own. So there is no one set list of things that this should be the most erogenic. There's nothing like that. It's a so what we call is pleasure mapping. So that's an exercise we give in psychosexual therapy for couples or individuals to figure out which part of their body is very erogenic for them. So it's called pleasure mapping. So that's a whole therapy technique that we use. Now let's move on. I'm mindful of time and the content we need to. So this we have already addressed, and there is nothing called vaginal orgasm is superior to clitoral orgasm. Nothing like that. So that's been busted. Now if you look at the male sexual response, now remember we had the whole cyclic, but this is sort of a very uh, primitive way of explaining. Not all men, but it's this is the popular way of explaining it. So the orgasm is up there. So it starts with the desire and then it reaches with the arousal and then we reach an orgasm. And what happens there is very important because, as I said before, so if you can see my video, which I believe you can, so from if you look at from this angle, gee, I don't know why I can't see myself, but let me open up. Yeah. So on the camera, if you look at my hands, so orgasm and ejaculation happens exactly at the same line for most men, not for all men, for most men. But technically speaking, they are two separate processes. So they're two separate, but if you look at from this angle, it happens at the same time. Now, this is the major problem because when whenever there is still no definition of male orgasmic disorder, or it's always tucked under delayed ejaculation or an ejaculation because they thought, oh, if we somehow define ejaculatory disorder, that will take care of orgasm, which is not necessarily true. And especially men whose prostate glands been removed, that's the most annoying bit because they can experience orgasm, but they cannot ejaculate. And we call that as dry orgasms because it's very annoying because much of the ejaculate comes from the prostate gland and which has been removed. So definitely ejaculation and orgasm are two separate but happen so close to each other. And it's high time that when we see clients, when we consult, we need to be able to see that as two separate processes, right? Now, in simple, physiologically, orgasm in men happens in two phases. One is emission and one is expulsion. Now, emission is all fluids collect from prostate, seminal vesicles, all the way up to the posterior urethra. And then expulsion is from the posterior urethra to the urethral meatus, external urethral meatus. But it's important what separates the two process is the pelvic floor muscles. Now, it's a complex mechanism, but it's the internal and external urethral sphincters. When they both contract, the pressure builds up. And when the pressure builds up, the pelvic floor muscles also contract. And finally, the expulsion happens, and that is the ejaculation. But that build up of pressure is actually, and release of that is actually the orgasm. And that's why it happens so close. But it's very important to understand, especially the glans penis, it sends all the signals, especially to S2, S3, S4. So anyone who has history of low back injury, we need to be mindful of why they are not able to experience ejaculation or orgasm. So it's very important. Now, once again, there are men who have hypotonic pelvic floor muscles, and that's why I've said that the key structure that we need to be aware of is the pelvic floor. And even we are seeing men with orgasmic disorders or not able to ejaculate, it's important to check on their pelvic floor muscles and how whether it's hypo or whether it's hypertonic. Right. So now let's get into the disorder side of things. So far we have discussed all the normal side, but now let's look into the diagnosis and more of the conditions that we can diagnose and treat. Now, I'm not going to read word to word in each of the slides. It's quite self-explanatory. You're going to get the slide deck, but this is the DSM-5 definition. So as you can see, in women, we are talking about female orgasmic disorder, which is marked delay or infrequency. It's happening, but it's not happening every time, or there is a complete absence of orgasm. Sometimes the orgasm is happening, but it is reduced intensity. And that's can be very annoying as well because one, there's an expectation that orgasm should be happening at a particular intensity based on what they have seen, or sometimes they themselves would have experienced something else, but after a certain life events, maybe the pelvic floor muscles could be a part of it, or could be a surgery, it could be a lot of pelvic surgery happening. That intensity might not be the same as what they used to experience before. So all of this is covered under female orgasmic disorder. And then we have either lifelong or acquired. Lifelong from first sexual experience, it's been the same. Whereas acquired is, or up until I had my childbirth, I was able to experience far better orgasm. But I don't know what happened afterwards. It didn't, it's not the same. Or it could be with, since I was with that sexual partner, my orgasms were great. But with the current sexual partner, it's different. So it's, so we need to take into consideration all of those things. And then based on the distress, we can classify as mild, moderate, or severe, right? But what we need to be mindful of, if you look at the number of women having orgasmic problems but have no distress, is twice the number of women who have orgasmic problems and distress. So what that means is if you remove distress from the definition, a lot of women do experience orgasmic disorders. But if you put distress, not everyone is going to be distressed, clinically significant distress. They have it, they are discomfort, they are a bit annoyed, but that's all right. Life can go on. So that's not necessarily distress. And remember, this is the American way of diagnosing things. Now, you practicing in India or me in Australia, we don't necessarily to follow or label or squeeze someone into the diagnosis, right? But it's good for academic purpose and good to have that as a reference point. Now let's go to the ICD-11. If you don't want the American way of looking at things, you want much of a global, which I tend to agree is far better explained, right? So the same thing, absence of marked infrequency or intensity. Now look at it. In women, it's slightly different. It's very much focused on orgasm, whereas in men, they just tucked under delayed ejaculation, right? So it's very important. Now, the key element when we are diagnosing orgasmic disorder is this third paragraph here, right? Despite adequate sexual stimulation. Now, what is adequate? It's not something we can dictate what is adequate. We need to explore that with the individual or the couple, okay? Provided they have desire for sexual activity. Remember, this is where the female sexual response cycle comes into the play. If a person is not interested in having sexual activity, but they are purely doing it to satisfy their partner because it's a chore, then that, and if that, in that situation, if that woman is not experiencing orgasm, that is not necessarily an orgasmic disorder. That's a completely different relationship issues or completely different problem, not orgasm. It's easy to point everything and pin it on orgasm, but from clinical experience of 20 years working in the spaces, be cautious in rushing in to give a diagnosis. Clients are not going to benefit from a rushed diagnosis. Rather, hold back, take history, just deal with the problem rather rushing into a definitive diagnosis. What I would recommend is start giving a descriptive diagnosis, because sometimes if you don't give a diagnosis, that can also make them feel that their problem is not being heard, they're not being considered serious, that they're just thinking it's all in the mind. So it's important to give some diagnosis, but it could be a descriptive diagnosis as opposed to, oh, this is what you got. No, it takes time for people to have develop rapport, And we need to explore quite a lot of factors before we can be definitive that this is genuinely an orgasmic disorder. So no need to rush into a definitive diagnosis. Now, I think I've already said this. Not every woman presenting with orgasmic issues have a disorder. Let's deal it as a difficulty. But once we have all history information, we have taken a thorough medication history, we have done a thorough examination, once we ruled out all hormonal factors, then we can have a definitive diagnosis of a disorder. So that's very important to as a takeaway. Now, what do we get out of this? If you look at this picture of this woman, is it pleasure or is it pain? Because there's a very fine line that differentiates the two. Now, sometimes you can argue, oh, that's an expression of pleasure, it's an orgasm, or is this a sign of pain? So just be mindful of that. Now, what are some of the issues related to defining orgasm? A, we have limited understanding, which I'm sure you would have got it by now. And there's lots of literature and data that relies on subjective or self-report because there is no standardized way of assessing and having any investigations to prove that this is definitely hypersensitive or low sensitive. So there's lots of tests, adjunct tests we can do to look at how sensitive the genital skin is and all of them. But that is not the standard. That's not the stock standard. But it relies heavily on subjective self-report. And the bigger problem is there is no universally accepted definition of orgasm. Yeah. Now, what we need to be mindful of that orgasmic disorders could also present with other difficulties. Now, these are all the different. Now, imagine someone not able to have an orgasm, but if they're having a genitopelvic penetrative pain disorder, the picture that I showed, they could be experiencing a lot of pain at the time of penetration. It could be dyspareunia or it could be vaginismus. Vaginismus, it's fear of pain, not actual pain. But the fear of pain results in contraction, involuntary contraction that could cause pain. So that's why they club vaginismus and dyspareunia together. So we need to be mindful. Yes, a person might present, doctor, I'm not able to experience orgasm. But if we assess them and say, well, there's a problem with you getting aroused in the first place, then that's a very different diagnosis. So just be mindful of that. Now, this is an article. Unfortunately, I can't share the article because it's a restricted access. It's not an open access. But if you can access it through any other means, through your professional body or some other means, it's fantastic. It's a great article. If you're really seeing lots of women with orgasmic disorders, I would strongly encourage you to get access to this article. But I will go through the gist of it, okay? Now, when we assess, we need to look into psychosocial factors, cognitive and affective factors, and relationship factors. Very important. Now, just keep a memory of this, just a pictorial memory, because we need this when we do the case study. Now, why psychosocial factors? Let's understand whether this person, what script does this person have about sex? Now, my stock standard question is, what does sex mean to you? It's a very simple question, but very hard to answer sometimes because, hang on a second, even you can try to answer that question of mine. What does sex mean to you at this point in time of your life? It could have been meant different 5 years ago, but now it might mean different. So that's sort of, and as they were growing up, developmental stages, what sort of messages they got about sex? Or when we say sex, are we talking about sexual intercourse or sex as an overall experience? So we need to understand how this person grew up as a person, as a sexual being. Now, cognitive and affective factors. Huge, okay? Especially women after giving birth, the body image and being made fun of it, the stretch marks. There are so many different factors that could be piling up in a woman's mind. So we need to understand what they're going through. Postnatal depression. If a person has depression, then they feel completely empty to be get that arousal happening. Right. So if you go to the female sexual response cycle, depression takes everything out of the pot. So they feel numb. They don't feel anything. It could be a very sexually arousing video, or it could be a very sexy partner, but still they don't feel anything on their skin. So that's something very important. Relationship factors, okay? The comments made about the partner, the way they talk during sex. And one other thing, if you haven't been made aware, we talk a lot about foreplay, which is a term I hate using it, because when we use foreplay, our mind is constantly thinking that the play is intercourse, when in fact, sex is everything you start doing from the time you start touching the other person or touch yourself. So I divide it as outer course, intercourse, not foreplay, play, or anything. Now, what lot of healthcare professionals don't look into or pay attention is what's happening after the so-called endpoint is achieved, right? That is called the afterplay, if you want to call it. But that's when the two people are communicating with each other. Hey, I really enjoyed today. Hey, I love this part of it. They don't talk. They think, especially men are terrible. They think sex starts when they get an erection and sex finishes when they ejaculate. Once it's done, they go wash their hands, if at all they do, and then they go to sleep or watch movie or something. There is no communication happening as much as it's happening before intercourse. Once it's done, they don't talk. And some women are crying. They are very sad. They had experienced pain, or they didn't feel connected. They felt like they just did it for the other person. So all of that could influence when they're trying to have sex the next time. But that the postcoital dysphoria is the term that we use, and that's very important. And remember, not everyone is a happy ending. People do end up in argument, anger, frustration after the sex is over, or when it is not over at all. So be mindful of that. And childhood maltreatment and abuse, a major factor we need to be mindful of, because sexual trauma, unresolved sexual trauma, could be a big factor, and that could be from known person, family members, religious leaders. That I've had history of women telling stories that you could never imagine. Okay, so there's lots of that happening. Medical history, if they have any other chronic disease, especially diabetes, and that's something we need to be mindful of. And now it's no longer called PCOS, it's PMOS, polyendocrine metabolic ovarian syndrome. So we need to be mindful of what else is happening in their general. Medications is a massive one, especially SSRIs or antipsychotics. But what we need to be mindful of, when a person has SSRI, do not jump and claim, oh, it's the SSRIs that's causing all this problem, because there's a high chance they might stop abruptly, which is terrible. So it needs a staggered reduction, but important to take a good history. And also when taking medication history, it's important to understand when the medication was started and what was the onset of the symptoms. Now, SSRIs is a funny group. Some people, you treat the underlying condition with SSRI so that they actually don't have a sexual problem. But for some, the side effect of SSRI is the sexual problem. So we need to be very mindful of how SSRIs can influence sexual functioning. Now, we need to take history of partner, because sometimes the partner might not be able to hold on an erection. Therefore, there is not enough stimulation. Therefore, the women might not be able to get an orgasm. So that's very important as well. Now, from a management point of view, there's a hormonal treatment is still there, but mind you, none of it has been validated. This is all hypothetical and some observational data and trial and error, but it's nothing been proven to be the gold standard treatment or on. It's mainly used as an off-label sometimes. Okay, and one of the reasons why we can't get a definitive treatment because the issues of diagnosing orgasm is very problematic. And there has been a big thing for the pink Viagra, but still that didn't go any further. But there's been lots of trials of using testosterone and PDE5 inhibitors to improve orgasmic function. But the gold standard is a thorough history is very important. A multimodal approach is important. When we know there are culprit medications like SSRIs or antipsychotics, then definitely weaning them and going for alternative, that can definitely have a better result, right? Now, the crux of the treatment will be sex therapy. Okay. Now, there could be directed masturbation training because a lot of women haven't even seen their external genitalia. So sometimes explaining to them the sex education of what is clitoris, what is introitus, and all of that is very important. And granting permission to talk about it, granting permission to touch their own genitalia. Sometimes they're not friend with their own body. So all of that could be very helpful. Sensate focus has been over popularized, but it takes a lot of effort, lots of guidance. And if they're in a partner situation, it takes motivation and commitment from both partners. But then you could do an eclectic approach of different techniques. Now, coital misalignment is another thing. In a in a heterosexual partnered context, sometimes remember the glans of clitoris is the most the sensory erogenic part, and sometimes certain positions does not arouse the area that is actually very erogenic for a woman. So sometimes changing the position could do a magic. And that's very important because if you look at it, when the penis is in that vagina, as shown there, front and back might not do much at all. Whereas when they're doing up and down thrush, that's where you're going to, as you saw on the video, the anterior side, that's where you're going to stimulate. There's lots of nerve endings, which is actually underneath the glans of clitoris. So you might get a lot more better outcome from changing the coital position. Try it. It's not like it must work, but it's worth trying different ones. Now, if you're in Australia, then there are lots of sex aids. I'm very mindful that India is also bringing in, but maybe that's something we can look at it where some of the toys where, like I have to recommend this to one of my male clients the other day. So you can actually wear it on the penis and then you can have intercourse with the sex toy to your penis, which will stimulate both the clitoris, but also it stimulates the shaft of penis. So there are lots of novel developments in terms of sex aids. I don't want to use the word sex toys because sex aids has a therapeutic connotation, whereas toys seems like it's just for fun. So it's important to, if you have access, then you can try it. Now, so let's leave this one, okay? So I think that the key points is we need to get the story straight. Okay, a lot of emphasis on history taking and what actually the issues are, and hold on to this. When we look at the case study, we will come back to it. Okay, now, as I said, it's okay for women to take longer time. Okay. And that shouldn't be seen as something negative. And sometimes it's okay to grant permission for women to touch themselves, be playful with themselves. Because sometimes if a woman doesn't know what is erotic for themselves, it's not fair to expect the other person to do anything. Okay. So there needs to be an open communication, and it's okay to spend more time in what we call it as outer course. And it's not always about intercourse. And that's a key message that has to be passed on from healthcare professionals, that sex is not just about intercourse, it's outer course and intercourse. And as I said, becoming friends, a lot of women, it's imagine there is a brick wall with their genitalia. So sometimes we have to break those brick walls, make them become more friendly, because for many, many years they've been brought up with this idea that's dirty, that is a no-go zone. And even the nerve that supplies the external genitalia, the pudendal means dirty. So that far the science been shaming that area. So we need to be able to reconstruct that. And there are so many different toys and mechanisms and vibrators. I don't know, Dr. Neeraj, how easy it is to access them in India nowadays. Is it
It's
easy, Dr.
available
Neeraj, to get
it's
these
available online. So many
online?
store are there.
Okay, wonderful. So, but remember, like any other field, there'll be lots and lots of different products. Just do your research and find out whether the material used is good. Don't go for always cheap, but I understand sometimes these toys can be pricey, but a lot of people who are experiencing these problems, they are quite okay to spend a bit more money and get a good product, because the rubber, the plastic being used, if it is suboptimal quality, that can introduce infection. And also how to clean those toys and keep it properly is another big issue, because a lot of times toys being used and then it left open, and then it becomes a perfect breeding ground for bugs. So it's important to talk about that as well. Now, there are different presentations, but let's go to the case study. I really want to do that. Now, these are all some standard techniques, like, we can talk as part of psychosexual therapy. It's okay to be asking, but once again, in our culture, I'm not generalizing all of us, but a women asking what they want is seen as no, no. But I am very mindful. Things have changed. India is progressing very fast. That's no longer the case. But India is not all about women in cosmopolitan cities. Okay, we are still having women who are still from a smaller community, still not that very forward thinking. So it's important to explore. Yes, they might be very well educated, highly successful business women, but still, when it comes to sexuality, they could feel very taboo and shyness. And sometimes women who are not well educated from a village, they can be quite open about sex. So we cannot make an assumptions based on their other qualities. So therefore, it's important to check with every woman, what values they have, and do they have any shyness, whether they have any doubts, and that's very important, right? So there are many things that they can do with the partner, and sometimes people don't know what to do in sex. They thought if sex is highly predictable, okay, sex, it happens the night time after having dinner, 11:30, he will come, touch me, then we'll undress, we'll go this position, we'll do this. So pretty much 2 days late before, you can predict exactly how that encounter is going to happen, then there is no thrill in it, right? So sometimes that sexual spontaneity is very important, but also allowing some space for variation within the sexual act with the same sexual partner, allowing for some surprises. I think that is also thrilling, and that's totally fine, and we can help couple to do that. And sometimes they feel ashamed to ask, okay, I want you to be in a certain costume. I want you to be in a lingerie. I want you to, let's have a shower together. So all of this, they might like it, but they feel shy of asking it, right? So it's important to educate them that it's quite okay. And this is what we do in psychosexual therapy, right? Now, in summary, I have given it, which we have already talked about it. Now, in men, I don't know what the time is. Okay, I'll quickly run through. So in men, the same thing we've gone through already, but the common etiology is the medications and low testosterone. And remember, always in men with either delayed ejaculation or delayed orgasm, always get their testosterone morning sample between 8 and 11, no need for fasting, but a morning sample is very important because it really annoys me when clinicians assess testosterone levels at 4 o'clock in the evening, because that's when they were able to see the client and they go to the lab and give a sample. Do not do that, and do not come into conclusion of testosterone deficiency based on one reading. We need minimum 2 readings and a morning sample, and also calculate the free testosterone. Along with testosterone, we need to look at their prolactin levels, which is very, very, very important, right? Now, this is based on a review article. It's not a thing, but I think it's pretty good. Now, the same thing, obtain medical relationship, psychosocial history, do any fancy test. This is biothesiometry, where you can check how sensitive the penis, skin, shaft, everything. It's not a routine, but if there is any underlying organic, treat them, stock standard. But look at this. This is where I get annoyed. So they say consider sex therapy. If there is nothing organic with psychological, consider sex therapy. And if that does work, go for pharmacotherapy. My point is, sex therapy has a role even if you're on medication. It's not like tick the box approach, right? So my way is bring down sex therapy. You can have it just on its own, or even if they're on medication, that doesn't mean they don't need sex therapy. Sex therapy still needs to be integrated into the management plan. Various medications has been proven to cause delayed orgasm or an orgasm in men, a whole list of medications, but there's also medications that are being trialed and used off label. But remember, that's why I put it in red and highlighted it. Most of the evidence is derived from very small cohorts with incomplete characterization of confounding factors. You can have a list, but the top carbapenem and bupropion are the most used. Others are still very thin evidence, but give it a try. But I would be very careful before starting someone on, unless you're confident in starting somebody on these medications. The evidence is not strong at all. Now, let's look into a case study, but very quickly, when we do case study, it's important to remember not all sexual problems are disorders. For some, it could be just a question, a concern. For some, it's a disorder, right? Always take a person-centered approach. Try to understand who this person is before trying to address their problem. Okay, I'm just doing a abbreviated version so that we can get to the case study. Now, the person might come to us with problems around their desire, arousal, orgasm, and they might have a reduced or absent satisfaction, which could result in distress, right? So that's where we call it as dysfunction. But their goal is to find a solution and move on. But our goal should be to help them. Our goal is not trying to put them in a box and give a diagnosis. Diagnosis is not the outcome. What do we do with the diagnosis, how we are going to help them navigate that problem and get to the desired outcome. That is really where our work is going to be important, right? Now, any problem with sex, sexual dysfunction, remember these 4 P's. Predisposing factors, why this person is having this problem. Precipitating factors, why this person is having this problem now and it not 1 year ago, not 2 years ago. So that's the second P. The third P is perpetuating factors. Okay, this person having this problem now, but what else is keeping the problem? Now, the fourth P is the protective factors. A person or a couple, when they come to us, it's not like everything they have is a problem. It's our role to understand, okay, what is there something in the couple that we can work with? What can we do better? What can we enhance? Okay, even though the couple has a problem, they have come together to solve it together. That's a good start. So let's work on that, right? Now, this is what I would give in a real world. If you're there in a room, we can do a case study, but that's not possible. But look, this is a case study, a woman that I saw a couple of years ago, and it's amazing. So she's a woman who went to a gynecologist and talked about Bangladeshi women who lives in Australia, and she's well educated, and then she got married to her husband, and they were in South Africa for some time, and then they moved to Australia. They have a kid, and then she had difficulty having an orgasm. She went to the gynecologist. The gynecologist said, and she said, this is creating a big relationship problem. And the gynec said, oh my God, what's the big deal about orgasm? Are you going to break a relation just because you can't get an orgasm? The patient felt that she wasn't heard, and the doctor minimized her problem and sort of ignored it. So she went to the GP. And then I was referred to see a sex therapist. And then her problem is not able to get orgasm during sexual intercourse, whereas she was able to do it during masturbation, but she wasn't very happy doing masturbation all the time. She wanted to be able to get an orgasm through intercourse. That's because her and the husband had a major relationship problem, and the husband always ridiculed her and criticized her that you can never get an orgasm. Even a horse can't get you an orgasm. And this has been the blaming and shaming in the relationship. She felt very, very sort of shut down. Remember the female sexual response cycle. Even though her husband does, and the husband actually had issues with erection, so he used to take a Viagra, has a full erection, doesn't do much foreplay or the outer course because he fears that his erections are going to go. So he thinks whenever he gets an erection, it's time for sex. He will come, he will do, and then he will somehow ejaculate and he goes to bed. And because she couldn't get an orgasm, she could fake it, but she doesn't want to fake it. But this is a problem, right? So this is 2 hours worth of history, and there's still a lot more. I have condensed it. Okay. Now, in sex therapy, we sort of part of it, we start clients to write the difference between an orgasm achieved through masturbation, which is MB, and then intercourse. What are some of the differences? And we work through this client. There's a lots of history and there's lots of cheating happen in the relationship. Finally, the couple actually broke with each other, and she was experiencing domestic violence. So she has to move out of the house with her little daughter. So there's a lot of story. And she had a boyfriend before marriage whom she wants to connect again. And then the husband also had an affair before marriage. So there's a whole relationship issues. Now, the bottom line is you can't expect a great sex life in a bad relationship. That's full stop. Now, whether this is a case of orgasmic disorder or whether there is a sexual arousal interest disorder, it's a combination of both. But this is an email that she wrote back in one of the follow-ups she gave. So you can read there, I didn't do much magic. As a sex therapist, it's important to validate, and that is very important. If the moment we make it all sound very simple, or a lot of women don't get orgasm, we think that we are normalizing it, but from a client perspective it feels like they've never been heard. So it's very important to give different perspectives, validate their problem, and hold the space, and that's very important in sex therapy, right? And In summary, orgasm is highly subjective and it's experienced in different ways across individuals and within the same individual across different occasions. And there are various descriptions of orgasm. There's lots of subjectivity. For some, it's a whole body experience. For some, it's a genital, and for some, it's a combination of both. And for some people, they read a erotic novel and they feel a very cognitive arousal and an orgasm, right? So there's lots of similarities in orgasm between men and women, but in men, it's always tucked into ejaculation, whereas in women, it's addressed separately. And there's good evidence that many women require clitoral stimulation. So clitoral stimulation is important, and clitoris should be talked about with women because a lot of people still think vagina is the sex organ, which is not necessarily true, and clitoral orgasm is not inferior to vaginal orgasm. So these are all some basic things that we can educate our clients. Now, one thing I want you to leave is sex is not equal to intercourse. Whenever we make reference to sex, a lot of people think intercourse because that's what we have programmed. But sex is not just intercourse. Sex equals to outercourse and intercourse. So if a person can't achieve orgasm through intercourse, what else? While we are working on that, what else can we do? Can we use outercourse to achieve that orgasm? It's a starting point, right? So I'll stop there and take any questions.
Tama, are you there? Naisargi, Tama, anyone? Riddhi, Naisargi, are you there?
Yes, sir.
Many
Yes,
women,
sir.
Yeah, so there are questions
many
in chat box.
women,
You can
yeah,
just put up the question.
Yes, sir.
yeah, I'm reading it. So many women expect spontaneous desire. How do you explain responsive desire? We don't have to have this or that. And sometimes that's very important. We shouldn't impose that desire has to be one way or the other, right? And it's okay for women to have that spontaneous desire, okay? And we don't have to say that but sometimes it's okay to have both, and it's important to give permission to have both, but we cannot dictate it. That how do you approach these conversations post-menopausal women? Well, definitely we need to take into consideration there will be hormonal and the early days of post-menopausal. It's going to be different, but doesn't mean you have to give up on that. And it's important to normalize that hormones have a significant role, but then do that person have a partner that is understanding, right? And how much of knowledge they had about menopause, what is their health literacy about menopause, how much do they understand, and what was their sex life before menopause happened, right? If their sex life has been terrible well before menopause, then it's not fair to pin everything on the menopause, right? So I think it's important to have a global understanding of their sex life is important. Can you explain again why orgasm don't always, sorry, I can't, I need to scroll it up.
Sir, can you
Can,
explain again why
yeah,
orgasm and ejaculation don't always happen together?
can you explain again why orgasm don't, no, no,
Sir,
it
question
happened.
is, its question is like, can you explain again why orgasm and ejaculation don't always happen together?
Why they are separate entity? Orgasm
Because
and ejaculation.
it's a completely different mechanism. It's a nerve plexus, everything is different. So in most men, I think that question refers to
Yeah.
men, it
Yeah.
does happen so close to each other that to an extent that you can't even separate it. But when one mechanism shuts down, that's when you'll be able to appreciate that there are two separate steps. Especially in men whose prostate been removed, you'll be able to see the difference. Until then, it is almost identical.
Sir, another question is like, normally which cases are you seeing in practice, lifelong cases or acquired cases more?
Uh, I would say more acquired.
Okay.
Mhm.
Then another question is how much does body image actually influence sexual dysfunction in your practice?
Humongous, a lot. When I say body image, not just the size or shape, the smell. Okay, I had a lesbian couple where one person they cannot stand the smell of secretions, right? And that's a big turn off. And they don't like to get anything dirty. So there's an aversion, okay? But body image, whether it is real or not, a lot of people have the thought that I'm not attractive anymore. It's only a thought, it's not a fact. But in therapy, we need to de-link the thought. Okay, this is what you think, but what is the fact here, right? But body image, not so much in the early, especially in the era of Instagram and all the social media, the adolescents having a big impact of body image, okay, especially body hair is very important, especially in a country like in Australia where there are multicultural, right? So a lot of girls, especially the young adolescent girls, if they are Chinese origin or other origin, they don't have hair. But hairless is seen as sexy. This is all we have imagined that way, right? Whereas someone with body hair is seen as less sexy. But it is purely based on the climatic conditions we are living. But when you're in a society when the majority is hairless and when somebody has hair, they obviously think that it's not attractive. So therefore, they go for waxing or laser treatment to become hairless, to fit within the norm. Mhm.
So one more question, like in compulsive
Mm.
sexual desire disorder, and what orgasm, like those people are having orgasm or not? I'm having one patient, she's having multiple partner, but she always complains she never experienced orgasm.
Okay. It's a very interesting question because when they stimulate, see, this is an issue if you start using vibrator, for example, okay? Or it could be a thicker penis, okay? Whatever the way the person, the woman is trying to get an orgasm, the body, the brain is processing that only with that level of intensity of thrust, they are going to experience orgasm. Now, over a period of time, it could be compulsive masturbation or it could be compulsive hypersexual, whatever you call it. After some time, that level of intensity is no longer adequate, right? So they don't feel anything. So what happens, Nasi, they actually, they put more pressure. They give extra pressure. And then it keeps going on like that. And after some time, the human body can only give certain amount of pressure, right? And that's when they switch on to vibrators. Now, vibrators comes with different intensity levels, 5 levels of intensity. After 5 levels, what are we going to do, right? So it's important. We call it as mindful masturbation or a guided masturbation, okay? Rather just going in and doing exactly the same way and just stimulating one particular part, it's important to have a, a bit more exploratory approach. Now, the good thing is, if you read about neuroplasticity, the brain has a capacity to reprogram, but it takes at least 1,000 times before you can reprogram the axonic connection. So it is possible, but it takes time and patience, right? And in your case, with multiple partners, is this person comparing how the intensity was with one particular person? Now remember, the length may not be a big issue. The girth of penis could have a significant role. And if the person is wearing a condom, then it may not give the same level. Now remember, with your patient, you need to check her pelvic floor. If her pelvic floor is hypotonic, then she may not have enough pelvic floor contracture to feel the rhythmic contractions, right? So there are have a good assessment.
Okay, sir. Thank you, sir.
Hope I
Sir, there
answered
is a
all your
one.
questions. Yeah.
Yes, sir. One question.
Mhm.
Suppose you put patient on the sex aid.
Mm.
Yeah. So how much it can be habitual? They can get orgasm with the sex aid, but not with the routine intercourse. So how commonly that can happen?
It This is like someone just buying it outright and without any education about use of sex aid. Yes, it is a problem, right? But I think it's important. And when we introduce sex aid in a couple situation, it should not be perceived as an alternate. If the couple are still in good relationship, they had good sex life, but now things are not happening the way it used to be, you can bring in the sex aid, but with some conditions, right? That you can still do your bit, and then the final moment you can introduce the sex aid, as opposed to, okay, today I can't be bothered, there's a sex aid in the room, go help yourself. It shouldn't become as an alternate. But for some women, that is the best approach. I can't be bothered asking him, I just want to enjoy whenever I want to have it, then it's fine. It really depends on what do they want to do it.
But ultimately, we are not achieving the to strengthen the bonding between the partner. Just we are trying to give the pleasure
True.
to women only.
That's right. But why we are assuming that the bonding is only going to happen with orgasm, right? Now, with the intention of having orgasm, the couple are ending up in a huge disappointment, which is anyway counterproductive. Now, what we can talk to that couple is, well, sex is not about intercourse. So why don't you have a lot of outer course? And then at the nth point, why can't you use a sex aid? And sometimes, Neeraj, having a plan B will give them confidence to do plan A well. Because there is this huge pressure that I should be able to give her orgasm. That pressure is going to have counterproductive effect, right? So therefore, let's have together. Let's play together. I think sometimes it's not as important as you think. I think one of the problems is we have given enormous importance around orgasm and sex when in fact it's not doesn't deserve that much. Mhm.
Sir, do you think
So I
that
have one question, sir.
yeah,
Yeah,
one minute,
I
one
hear.
minute, 1 minute, 1 minute.
So,
Sir, there is
so
one
now when
question.
so
Yes.
when a newly married couple, as you said, she's under the tremendous pressure of having an orgasm. So having an orgasm, but she's not able to, in spite of completing her sunset focus, mindfulness, that pressure of orgasm is not released. Then how can
Hmm.
we go about it, sir?
Okay, what does she do? It's a whole case, okay? So I need to know a lot more about this person, right? So do they have adequate sexual stimuli? Now, whether she has ever experienced orgasm in any other way, and what is her definition of orgasm, Vaidehi? What is her definition of orgasm? Have you explored that?
Okay.
And that's very important in couples, okay? Because they read somewhere and they have an unrealistic expectation and they think, I'm not experiencing orgasm. But when you actually look at it, they are experiencing, but it is very pulsated. It's not one build up and one release. It's quite pulsated. So, understanding how her pelvic floor works, understanding what does sex mean to her, understanding her definition of orgasm. We don't have to define orgasm. Let her define what orgasm is. And it's also important to understand what is happening behind the story. Is she being forced to experience orgasm? What is the imminent consequence of her not having an orgasm? And as I said, there's lots of myths about orgasm. Okay. If I can't experience orgasm, that means I'm not enjoying the sexual partner. right? If I'm not able to have an orgasm, I'm somewhat inadequate. I'm sort of not up to the mark as a sexual being, right? So where this is all coming from, so we need a quite a detailed history. Now, is she on any medications that you're not aware of, right? And let's not assume that when she says they have vaginal intercourse, are they really having vaginal intercourse, right? And just because that your client might be well educated, that doesn't mean she knows everything about sex. So, yeah, Dr. Neeraj, you had something to say?
Yeah, sir. Is there anything like orgasm gap, and how will you manage if there is a some sort of orgasm gap between partner?
Well, that's an interesting question because couples also think they need to have a simultaneous orgasm. In movies, it's very commonly shown that way. It can happen, but what is the real purpose of having simultaneous orgasm? What greater good it's going to do? Once again, it's interesting how the mind plays. The moment you start expecting this, and this should happen in sex, the opposite actually happens because this is the power of should. Whenever we condition something, it actually counterproductive. So sometimes relieving that should and let it take a natural course can be very helpful. But once again, we need to understand what does having mutual orgasm, what does that mean? I think, say for example, if a woman gets orgasm first, right?
Mm.
In my clinical experience, lot of men with premature ejaculation say that my wife is not happy, when in fact the women are not happy by the time that he ejaculates, but more so by the fact that he starts, he finishes, and then he walks away. He just started me on this and then just dropped me there and walked away. Rather, if you change the narrative, okay, why don't you focus on her pleasure for once? Why don't you work on her pleasure mapping? Why don't you make her achieve an orgasm? And then once she achieves an orgasm, you do the penetrative sex, you come in 1 minute. Honestly, a lot of women are not even going to be bothered. And some women are actually relieved that it's done. Well, once again, I'm not dictating how it should happen, but this is the question we should to ask them. How do you want the sex to happen? Yeah. Vaidhi, I think you got dropped. Do you want one more question? Dr.
Whether
Vaidhi?
you are have two devices, so you can log out from one device.
Yes, sir.
Yeah.
Yes, sir.
So
Sir,
many
No,
is
no,
there
you were asking, you
sir,
got
another
dropped.
question? Yeah.
So
Yes,
management
nice.
All right.
will ask couple, but they don't have history of foreplay only. So they are having only penetrative sex, and because of that only they are not getting this orgasm and they are not having satisfaction. So mainly, I think 60%
100%.
couple are giving same history. They don't know about foreplay.
Well, do not use the word foreplay
Of course.
Yes.
because
Of
the
course.
moment you say foreplay, their mind is thinking of play, right? So one learning today, Dr. Naisagi, is eliminate the word foreplay and
Yes.
introduce and replace that with outer course.
Yes, sir.
Okay. And remember, if the couple is not planning to fall pregnant, I'm telling from 20 years experience, outer course can be equally pleasurable as intercourse, and sometimes outer course can be more pleasurable than intercourse, right? And that gives a whole new opportunity for your couples, right? And sex doesn't have to be so strictly scripted that it should happen in the nighttime. Who says that? Sex should happen in the bedroom. Who says that? provided it's legal to do, they have enough privacy. If they have all the means, sex could happen on the couch, on the lounge. Okay. But we have this notion, and be very, very brutally honest as a medically trained person. You had a whole day of work and stress. Then you have a big fatty night dinner. And then the 11th hour before you go to bed, you really want to do sex? And then you start a disappointment with that performance. Why don't you do sex when you're fresh after a good night's sleep? Why can't you do it in the daytime? Why can't see this is the very important in sex therapy, what we say. You you both consider this as a very important aspect of your life. You both wanting to get this right. Why don't you show some effort and importance and take some time to do it in the daytime? Right? Or kids, well, why don't you take a day when the kids are at school or leave them somewhere and or work? Well, take half day of leave when you don't have any responsibilities. So that there are many ways, and I've had couples for whom when sex, every time they had sex, they had it in the night time, 11:30 before going to bed, never was good. Once their daughter was at school, they both took leave, half day leave. They had sex once the kid all they had an amazing sex, right? It's not about the performance, it's about the overall experience. Mhm. Yeah. But you have my contact details. Please reach out to me if you need any further tips or if you have a specific case, happy to discuss. But I think I will call it a day, Dr. Neeraj. It's
Okay, sir.
quarter
Thank you,
past
sir.
10. But thank you for the invitation.
Yes. Before that, sir, just wait for vote of thanks from Dr. Nesargi.
Yep. Yep.
We can't hear you, Nesargi. You are muted. Unmute.
Yes, sir. Yeah, unmute yourself. Yes.
On behalf of organizing committee, I extend my heartfelt thanks to our esteemed speaker for sharing such valuable knowledge and insight. We are truly grateful for your time and expertise. My sincere thanks to our President Dr. Neeraj Yadav sir and Secretary Dr. Apurva Datta, MOC Dr. Riti Shukla Madam, conducting this today's program, and special thanks to our delegate for your enthusiastic participation and engaging present, which made this webinar great success. Thank you all and have a wonderful day.
Thank you, Nasagi.
Thank you,
Thank
sir.
you. Thank you, Dr. Rich. See
Thank
you
you.
all. Thank you, Dr.
Thank you,
Shama.
sir. Thank you.
Thank you,
Thank you
Dr.
so much,
Riddhi.
sir.
Thank you,
Thank you,
sir.
sir.
Bye-bye.
Thank you.